Good morning.
Good morning.
Morning.
Well, that sounds better.
Morning.
Good morning. My camera it keeps giving me an error code, so you don't get to see me. But I promise it's for the best. Let me get everybody admitted here. Okay, so first off, did everyone see the library announcement about how to go about making copies, printing, etc.?
Yes.
Good. The course calendar, I just realized, I posted an announcement last night about having updated your course calendar, and hopefully this would be the last time that I did this so that you now have all the information. But what I just realized was the class meeting times are wrong. But I hope that you are just intelligent enough to overlook that. Like, for example, I think I even quit putting it after week 4. The class meeting time that says 9 to 10:30, please ignore that. You know what class you're in. And yeah, the rest of the class days, I didn't even put the class meeting because unless it was test review, because I think that's just kind of understood. But in case you did not see that announcement, under your syllabus tab, you have this lovely course calendar. I went back and bolded. Am I sharing my screen? I'm not.
No.
I'm just talking to myself like you guys can see it. I'm sorry. Hold on. I am so sorry. Now can you see it?
I can.
Yes,
Okay.
ma'am.
Yes,
Okay.
ma'am.
So now you have this course calendar. So I went back and bolded the actual day. Like, for example, today is September 18th. It is the beginning of week 5. And I bolded the beginning just in case. Because, I mean, the course calendar is even confusing to me sometimes, depending on how sleepy I am. So today's September 18th. For this week, you need to get your test questions submitted for exam 2. Make sure that you've studied both of the respiratory recordings. They're both on Canvas now. And just prepare for exam 2. So I've got, and we'll go over this more in a minute. But after that, next week, we're going to have our group test review. And you will have part 2 of respiratory to start working on after you get past the test next week. Then we have the pain management lesson, then infectious disease and vaccines. That will be on exam 3. So we have respiratory part 2, pain management, and infectious disease for exam 3. For exam 4, we'll have gastrointestinal and part 1 and part 2 of cardiac. I took out a chapter that I don't even know why I put it. Every semester I add a chapter just in case, but I took it out. So I want to split cardiac. It's how I've always done it. It's just too much to try to do it in one week and you to actually absorb anything. So exam 4 will just be GI and cardiac, but cardiac is split over 2 weeks. There's a part 1 and there's a part 2. And then for exam 5, we have hematology, neuro, endocrine, and emergency. So I know it sounds like a lot, but hematology isn't that bad. And neuro and endocrine, I just choose certain parts of the chapter. So you have two PowerPoint recordings for that week, but it's not the entire chapter. It's just what I pick out of the chapter, and it's not bad. Emergency, even though it says chapter 34 and shock in chapter 46, the majority of the material comes from the PowerPoint, and that's what you'll need to focus your studying on. It is based on PALS, Pediatric Advanced Life Support, and it covers topics that I think that are important for a pediatric nurse to be familiar with. Dealing with emergencies, it's just stuff that in my personal experience, the things that I think we need to know that's the last thing that we're going to cover. So, and then this final exam review PowerPoint is a PowerPoint I put together that's just full of questions. It's nothing but questions. And if you watch it in PowerPoint mode, then you don't see the correct answer until you try to advance to the next slide or press the space bar or however it works on your device. Once you press the space bar, it will underline the correct answer, so you'll know. It's not an audio recording, it's just a PowerPoint, just to kind of help you review stuff way back from the beginning all the way to the end. So now, since I went ahead and filled this out completely, there are some things that are not on here, such as the videos, because I just haven't had a chance to put all of them up there, and it's too wordy to even try to put it all on the course calendar anyway. So what I did was, if it's something that I knew for sure would be happening that week, like I know for sure you'll have a Toradol article. I know for sure I have a video related to Mickey buttons in the GI chapter, things like that. I did go ahead and put on the calendar, but otherwise, when you look at Canvas, this is your class 210-802. When you look at Canvas from now on, if I have put extra videos on Canvas that may not be mentioned in the course calendar, the tab that says lecture and notes, I will put a comment out here that says assessment videos or child life and PIV videos. This week we have some respiratory distress and croup videos. Do you understand what I'm saying?
Yes, ma'am.
Okay, so
Yes, ma'am.
So don't forget to click on, even though your printable PowerPoint is here and your 2 respiratory recordings are here, don't forget to click on lecture and notes, because that's where you can find additional videos, if I have any, for that chapter, just to help reinforce the material. Okay, so these are the videos that I added last night, and then also my internet's being slow, but I'm pretty sure I added the second one here too. We'll just give that a minute. Also, your recorded videos are under the notes section. If that doesn't pop up, I'll need to go back and add it, but I'm pretty sure I did. Did y'all see it under this section this morning? Maybe I forgot it.
To be fair, I didn't look at it, so I don't know.
Well, I'll be sure and go back and check. If it's not there, it's not the end of the world, because it is here. I just saw it. My internet's being slow. I'm sorry. And my mouse keeps freezing up. Okay. If you look under week 5. This is the second video. The first video did respiratory anatomy through strep throat, and it cut me off when I was talking about strep throat. And the video I posted last night picked up with strep throat. I kind of started over on that, and it finishes with croup. So if it's not under the lecture and notes page, it's here under your module. But I'll try to get that corrected. Okay. So as far as studying for our tests for next week, you need to study physical assessment. You have one PowerPoint, and you have the chapter readings, and you have 2 recordings for physical assessment. It's pretty straightforward. Remember that your questions are typically scenario-based, expecting that you understand the concepts, you understand the pathologies, the anatomy, and you know how to appropriately intervene, prioritize, respond, educate, things like that. Also on this test is chapter 35. It's easy. It's just chapter 35 does not have a recording. It is just talking about the child that is in the hospital and how they respond depending on their age, how they cope, the types of stressors that an infant versus a toddler versus a preschooler and so on would have. You know, which age group is most at risk for anxiety due to being separated from their parents, or stranger anxiety? You tell me. Who's afraid of strangers? Who's going to freak out when you take them away from their parents the most? What?
The toddlers.
Toddlers, that's right.
Toddlers, yeah.
So that's the kind of stuff that it talks about. It's easy information. A lot of it you already know because we've had it from other chapters. It's just applying it specifically to a hospitalized child, okay? And how we can help decrease those stressors and intervene appropriately, you know, based on the knowledge that we have. So we have physical assessment, the ill or hospitalized child. I took out the chronic chapters. And then we have respiratory part 1 with these 2 recordings. In your chapter, only focus on the topics that are covered in these 2 recordings or this PowerPoint. Those topics are the anatomy and pathophys of a pediatric airway versus an adult airway, and then recognition of respiratory distress versus failure. And then we get into our specific diseases, beginning with viral pharyngitis or viral sore throat, group A strep or strep throat. Then we talk about tonsillectomy and adenoidectomy and post-op care that goes with that. Then I believe, I'm going to pull that up. Okay, viral pharyngitis, then group A strep, tonsillectomy, adenoidectomy, post-op care. Then we have apnea and bruise. And you will note on my recording, I called them bruies, and I found out after I recorded it, I don't think that's the way it's pronounced. I think I should have said bruise, like a brew. That's the way I heard it referred to in a video that I watched. So just forgive that I called it a brewy, but it's brew. So I will talk about that. And then the last thing is croup or laryngotracheobronchitis. So those are the only topics in the respiratory chapter that you should be focused on for this test. Croup, brews, apnea, TNAs, strep throat, viral pharyngitis, and just basic respiratory stuff. Okay, any questions about respiratory? We're going to talk some more about it in a minute, but just based on what I've told you right now, are there any questions about respiratory?
No, ma'am.
No.
Okay. Let's see here. So what I want to do is take you to the lecture and notes tab for respiratory. And I want us to watch some of this because these are good videos. And if you have not explored Open Pediatrics, I encourage you to do so. There's so much good material there that I've used in my classes. It's too much to post for you guys on Canvas because it would overwhelm you and you would think you had to watch them. But Open Pediatrics is a free resource. It's scholarly, it's up to date. It's for nurses, physicians, you know, whatever you are. Some of these videos you may have noticed are geared towards nurses, but some are geared towards the provider, like the physician. So, for example, in the croup video, if you hear them talking about how to diagnose croup, don't get your feathers ruffled about that. It's because the video was made for somebody, you know, that's training to be a doctor. But all the other aspects of the video are perfect for helping us be able to recognize a child with croup, their symptoms, the way they sound, and the management. We're the ones that follow the orders, so we're expected to understand appropriate management of a patient with croup. So don't get stressed out if it sounds like I'm trying to tell you you have to diagnose the patient, because that's not what I'm doing. They're just interesting videos. So it looks like we have 21 people here, and I'm one of them. I'm wondering who we're missing. Do y'all know of anyone that was not going to be able to make it? Devin? Oh, Ashley and Nina are counted as one, I bet. Devin?
Like these songs.
Oh, it's just me. Nana's not with me.
Oh, I said not Nina, didn't I? Sorry. No.
I just didn't change it from the last time when we had our test review.
Can y'all see the participants? Like, is it sharing it on my screen?
Yes, ma'am.
If you recognize anybody that should be here and is not here, let me know, because I don't have my list in front of me. Okay, so I'm going to play this, and if it's blurry at the beginning, it's just my internet, and it hopefully will clear up, but it's not really a blurry video. And I tried to fast forward it to skip the credits at the beginning.
Things is causing respiratory compromise. Typically, the compensation consists of an increase in the rate and work of breathing. That increase will increase minute ventilation, allowing the child to exhale more carbon dioxide when gas exchange is impaired. Signs of respiratory distress include retractions, sternal retractions, for instance, because of the flexible, compliant breastbone, as well as intercostal retractions. And this is an example of increased effort resulting in muscles exaggerating the spaces between the ribs or in the sternum. Use of accessory muscles, such as the strap muscles in the neck, nasal flaring, and grunting, an expiratory noise that's designed to apply some PEEP. Children in respiratory distress typically are anxious. This is an uncomfortable feeling, and with that stress, they oftentimes have tachycardia. These are some examples as well of signs of respiratory distress. The child who wants to sit upright and is unable to lie flat comfortably. The child in the left looks anxious, and the child in the right is demonstrating increased work of breathing. Respiratory failure, on the other hand, is at the other end of the spectrum and is defined by inadequate oxygenation and ventilation. Essentially occurs when compensatory mechanisms fail to maintain gas exchange. Interestingly, respiratory failure can occur without preceding respiratory distress, meaning it can happen when there is depression of respiratory effort, typically by something like a poisoning, which depresses mental status, or seizures, or severe weakness, leading to inadequate respiratory effort. Signs of respiratory failure when the compensatory mechanisms are no longer able to sustain gas exchange include desaturation or cyanosis despite supplemental oxygen, the appearance of increased effort leading to poor air entry. In other words, lots of work for very little gain. This may be characterized by a sound of gasping when the child inspires, head bobbing, which is an exaggerated form of accessory muscle use in which the head literally will bob as the muscles of the neck and shoulders are trying to participate in gas exchange. Seesaw or paradoxical respirations, where the abdomen and chest move in the opposite ways than they usually do. And sounds of severe obstruction, such as stridor. A hallmark of respiratory failure, to distinguish it from respiratory distress, is a change in mental status. When oxygen levels fall and carbon dioxide rises, this is a very stressful feeling and results in sympathetic stimulation and agitation. As carbon dioxide continues to rise, it has a sedating effect on the central nervous system, leading to a child who's lethargic, sleepy, or obtunded. The child who appears to have increased work of breathing, desaturation, and sleepiness or obtundation is one in whom you need to be very concerned, has transitioned from respiratory distress to respiratory failure, and may progress to respiratory arrest and cardiac arrest.
All right, bye. Okay. So, did you hear grunting in that video?
Yes.
And, you know, go back and listen to it as many times as you need to hear that. So what, and you know, there's lots of good videos like this on Open Pediatrics that you guys can go listen to, not just for respiratory. When we get to cardiac, I use their stuff for that as well. Anyway, PEEP, she talked about having grunting is a form of compensation that the child uses to try to generate an increase in PEEP. And my question for you is, do you know what PEEP is?
No.
So I'm going to draw, and you know that's always exciting when I draw.
Peak expiratory pressure.
Who said that?
Me?
Who is you? Stephen?
Steve? Yeah.
So here's your lungs. And you have your main bronchus, Come on, mouse. You have your main bronchus. Oh my, did I do that? Stop. I don't know what's happening. Sorry.
That's beautiful.
Yes, you have you have your main bronchus, and then you have your, your main stems, and then off of this you get it just gets better and better. Here's the point: you have all these little tiny branches, right, that come off into your lower airway, and off of those you have these little sacs called your alveoli, and to keep these little sacs from collapsing, every time we exhale, we have to have pressure to keep them open. And you've probably never thought about that before, but we have a physiologic pressure, or PEEP, that keeps our lungs from collapsing every time we exhale. And when I say collapsing, I am referring to the individual alveoli, those little sacs. If they were to completely collapse at the end of every breath, it would take much more effort on your part to initiate the next breath. Okay? So that's why it's important that they stay open between breaths. The pressure is called PEEP, positive end expiratory pressure. So that's what PEEP is, positive end expiratory pressure. That's what the PEEP stands for. And physiologic PEEP, or the pressure that it takes to keep these alveoli open, is about 4 to 5 centimeters of water, H2O. I don't know how the Khan Academy guy does it. I don't get it. I guess he has a fancier computer than me. So I'm telling you that you're all walking around with about 5 centimeters of PEEP, 5 centimeters of water pressure, a PEEP of 5 right now. If a child is sick and has an obstruction in, I wonder if they're, oh yeah, color. And they have boogers, they have mucus obstructing these airways, all this pus and nastiness, and they have inflammation that's causing swelling, all this is inflamed. They have all these boogers down here in the lower airway. This is a lower airway obstruction. Then they have decreased lung compliance. Their lungs are sick. It's harder to get air in. It's harder to get air out. Everything is complicated now. So they require a higher PEEP to successfully ventilate. If we had them on a machine breathing for them, we would manipulate the PEEP, the pressure. We could apply the pressure that they need to keep their sats up and to keep gas exchange happening. But we're talking about a baby that's not on a machine, and they're making a last-ditch effort to be able to breathe and not go into respiratory failure. That last-ditch effort is grunting. And by grunting, when their glottis closes up here at the top, they're using that as their PEEP valve. They're using that to when they grunt, they push against that closed glottis to increase their PEEP on their own. On the next section of respiratory, when we talk about ventilators, you're not going to be tested on this. I just talk about it to expose you to it, to help understand the big picture. You'll see the setting on the ventilator where we can increase their PEEP. If you walk into a patient's room that you're taking care of and they're on a PEEP of 5, that tells you right off the bat something about how sick their lungs are. Like, I'm not going to freak out if my patient is on a PEEP of 5 because that's normal PEEP. If, uh-oh, my son's coming up the stairs. Lordy, what's he going to say? I don't think he's talking to me, though. Okay. What was I saying? If instead I walked into the room and my patient was on a PEEP of 10, then I am going to be much more concerned. Hang on 1 minute, guys. What is the keys? Are they not in the car? Oh, I'm sorry. Be careful. Okay, he was taking my car to go to physical therapy. Okay, so a PEEP of 10 versus a PEEP of 5. That tells you something about your patient. Keep in mind when we talk about pressure, the human body, the inhalations that we initiate are using negative inspiratory force. It's called the NIF, N-I-F, negative inspiratory force. And my mouse is going to go cuckoo again. Here we go. NIF, negative inspiratory force. That's our natural inhalation is using a negative force. When I apply a breath to a patient using a mask and an ambu bag, what do we call that? Anybody know the 3 letters we're going to use? Stephen? Nobody?
Nope. Ain't got a clue.
Good. I can be the smartest one in the room. PPV, positive pressure ventilation. You did know that. You just forgot you knew it. CPR, when in CPR, when we bagged our mannequin, that was called bag valve mask with positive pressure ventilation. That's what your CPR book, your BLS book called it. And it might have just went in one ear and out the other, but that's what it was talking about. When we put a mask on somebody and we force the air into their lungs, we're using positive pressure. And when we, on that same note, increase the PEEP, the artificial PEEP, and we apply a higher pressure to their lungs because that's what they need, it's not natural. And it can even be dangerous and cause damage to the lungs. And we're in, like, when I say cause damage, we could cause a pneumothorax. But if you have somebody whose lungs are so sick, they've got to have a higher PEEP, you know, you're caught in the middle. If you don't do it, they suffer. If you do it, you're risking causing damage. So, you know, that's something we'll get into more later, but basically the baby that's grunting is trying to increase their vent setting to a PEEP of 10 or a PEEP of 7 or 8 or whatever it is that they need to overcome all this crap in their lungs that's going on. A PEEP of 4 to 5 isn't cutting it. So they grunt as a way to naturally increase their own PEEP. And I hope maybe some of that made sense. Okay. Now, while we're still talking about distress, this video is a little longer and we're not going to watch the whole thing right now. I just want to show you the beginning, some of it at the beginning, and then I'll stop it. But I want you to watch all of it when you have time.
Tachypnea. When a child has a problem of any kind that interferes with gas exchange, or they need to excrete more gas, as in the case of a time when they're producing more CO2 than normal, their very first attempt at compensating for that is to increase respiratory rate. And so tachypnea is by far the most common and universal sign of respiratory distress in an infant. Unlike an adult who does have a more expandable chest cavity and stronger intercostal muscles, the infant breathes already at a fairly high lung capacity. And so that their ability to increase volume, tidal volume, by compensatory mechanisms is limited. It's much more efficient for them to breathe fast. And that's why tachypnea is the somewhat uniform or universal sign of respiratory distress. Now there's comfortable tachypnea, which typically occurs when an infant is demonstrating a compensation for some primary lung problem like interstitial edema, something that will reduce compliance of the lungs. And by being more tachypnic, they'll increase minute ventilation, which is tidal volume times respiratory rate. And this quiet, comfortable tachypnea can actually get to pretty significant rates. It's not unusual for a young infant to be able to breathe at 70, 80, 90, even 100 times a minute and not look particularly uncomfortable until one stops to really count that respiratory rate. Of course, breathing that fast uses a lot of energy, and so while the infant may be able to maintain that for a period of time, it's one warning sign that respiratory failure or decompensation may develop.
Nasal flaring.
The other signs of respiratory distress that are important to look for are nasal flaring, which is essentially a way of increasing the size of the upper airway, which is a somewhat high resistance place for air to flow into. And by flaring the nostrils, one is making that passage just a bit larger.
Retractions.
Another sign is retractions. Retractions occur when there is collapse of soft tissue because of muscular effort. And one can see retractions in a number of places when an infant is demonstrated increased work of breathing. And so their muscle activity is increased in an effort to increase tidal volume of the lung, but this is a really limited compensatory mechanism because of the shape and size of their chest. Retractions can be seen in a number of places. Suprasternal retractions, or the jugular notch, it's a common place. In between the ribs, called intercostal retractions. A very common place is substernally or subcostally, which you can see being demonstrated on this baby as an example of when the abdominal muscle significantly contracts and reveals the edges of the rib cage. In a very young infant who has a very compliant chest wall, one might even see the sternum collapsing significantly because of their effort of breathing. And the muscular effort is strong enough to make that soft cartilaginous sternum collapse. And those are, of course, sternal retractions as opposed to subcostal or substernal retractions.
Grunting.
Another sign of respiratory distress is grunting. We're going to demonstrate grunting in just a moment, but grunting is a mechanism by which the baby tries to maintain lung volume. It's essentially closure of the glottis and breathing against that closed glottis to provide some peep to oneself and therefore hopefully maintain alveolar volume. And so our baby is now going to do a demonstration of grunting. Thank you. Grunting, as you can see, is an expiratory noise. It's sort of low-pitched and coming from deep in the throat because that's where the closed glottis is occurring.
Seesaw breathing.
Okay, so that grunting example wasn't the the best, I don't think, because it sounded too artificial. I like the one on the previous video, but the point is the same. It sounds like a vocalization because it's coming from the throat, and it is on expiration. So anyway, I like that video. It's pretty good. So now I want to do this, and I'm not going to make you watch the croup video right now, because what I would like you to do is once you have watched the recording that I posted last night, then come back after you hear what I have to say about croup. Then I want you to come back and watch the croup video and recognize in the video the things that you grasped from what I said, the things that you remember, the things that make sense, and you kind of realize, oh yeah, yep, that's right, I remember that, okay, yeah, and you realize that you remember stuff and that it makes sense and it's all coming together. Some of the things in the video you can add on, like it points out certain viruses that I didn't mention that are possible causes of croup. It's good information, but I'm pretty sure this is the video that also talks about diagnosing croup, and don't get freaked out about that. It's not a big deal. Just learn from it and let's move on. So yeah, I'm still not seeing the other video here, so I must have forgotten to add it. So I'll have to come back and add the second recording in this section. But like I said, regardless, it is in the modules. Where is it? Here. Strep through croup. Now, I'm trying, there was also, I believe in that first video, there was a good audio of stridor. I wish it lasted longer so you could hear it, but the stridor and the grunting examples in the first video that we watched together, those are good examples. Ask me questions. That's all I have. What do you want to know? Nothing? Y'all are all just, you all have it together and you don't need me at all?
I might ask questions later on, but I haven't read the book yet, and that's usually where I get the most confused.
Yeah, I haven't gone through all the readings yet.
So really print out your PowerPoint, or however you guys do that. Look at your PowerPoint before you read the book and mark the sections that you need to look at. Don't waste time studying something for this test that's not going to be on the test. So do you understand what I mean by that?
Yes, thank
Okay.
you for the tip.
So when I say here,
Yes, ma'am.
review the PowerPoint and correlate with chapter, that's because that's what I do. It's boring to just teach straight from the book. And there's some things that I think are more knowledge worthy. So it does skip around some in all the chapters. So look at your PowerPoint and highlight the areas in the book that you need to focus on as you're listening to the recording. So you have Kaplan Pediatric A that is assigned for next week. Now, remember, you can do that whenever you want. You can do A, B, and C all tonight if you want to. But the way it is on the course calendar, it's spread out just so that you don't forget to do them and have to do them all at the end. They're meant to be practice. So remember, you need to achieve an 80% before you can consider it completed. It's not a big deal if you don't have it done by a certain date. It just needs to be done by the end of the semester. But I think it behooves you to start working on it anytime you have a chance. There's no articles for this test. It's just the student test questions and what you have posted. Is there anyone in this class that needs to come use the Wi-Fi at BIPSI? All I've got so far are 2 people from the other class. If there is, let me know, and I will open a room and, you know, make sure a room is available for you to bring your computer up there and take the test. We had a very intense, long, 2-hour-long faculty meeting yesterday, trying to resolve the testing dilemmas and confusion. There's a lot of anxiety and stress and emotions on your end, but it is also present on the faculty's end. We almost had some tears. We had some, I wouldn't say angry, but some tense moments, and the dean was there for all of it. And from what I hear, there has also been some harsh words between faculty and students, and students and the dean, and that's not okay. So please remember to be very careful in your language when you speak to the faculty or the dean, no matter your stress and frustration, just like I have to do when I speak to the dean or my boss. No matter how stressed out I am, I have to be professional and respectful. Or the resolution to my problem will be that I will be fired. And you don't want the resolution to your problem to be that you will be dismissed from the program. So be very careful about that. Now, putting that aside, this is very difficult. This is unprecedented. You know, we don't know how to make this work just straight out of the chute. We don't know. We've never done this before. And Miss Burroughs had Miss Humphrey ask you guys a question, but it was just a question. It was not saying we are going to come to campus. We are going to do this or that. She told her to ask, she asked, and it was, in hindsight, probably not the best way to handle it. But at the time, they didn't know that. Everyone got more upset and things got ugly. The resolution is this. What I posted on my discussion board and the announcement for you guys is the answer. And that's what all the instructors are going to do. We cannot fix it where you can all come on campus and test. We can't. There's not, because of social distancing and the capacity rules that we're having to follow. If we push that and say, oh, but we're special, the nursing students can do it, then what's going to happen is that we're going to end up going back to phase 2 because people are going to start getting sick. We cannot break the rules. The testing center has limited capacity. We have 2. One they set up in building H, and then the original testing center. But because of the social distancing, even though there's 50 computers, only 15 people at a time can be in there, and it's only open on Wednesdays and Thursdays. It's not fair to have some people pay for ProctorU and other people not have to pay. Nursing school is expensive. I don't feel sorry for you, and I know that sounds harsh, but let me tell you this. I graduated nursing school with my bachelor's in May of 2000. I owe $42,000 today, still. I've been paying on my loans for 20 years. I didn't get grants. I didn't have scholarships. I'm going to be paying on student loans until I die. And I can't think about that, and I can't be angry about that. That's what I had to do. You're not special being broke and having to take out loans. That sucks, but that's part of nursing school or college period. And the $15 test, I mean, really guys, that's got to be the least of our problems right now, because this is stressful. This is very, very hard. So the only thing, after 2 hours of round and round and round, on top of the weeks of us trying to figure this out, the only solution is that there is no solution except to keep doing ProctorU. That is the only solution. And for people who do not have trustworthy internet access and are consistently having problems, we will make sure we open a classroom on that campus and let you come up there and take your test. We will do it. We will do that. The testing center, the regular testing center, and if that works for you and there is no one that can come up there and open a room for you, you know, there's always that option, but we will work for you in that sort of situation. But we can't fix it where all 57 of you can come to school and take your test on Canvas and not have to pay. We've explored every option and we cannot make it happen. So please go easier on your instructors or instructor before she jumps off a bridge, because it's almost to that point. And I'm not trying to talk about other people, but I know what's going on, and I know you know what's going on. And I just don't know. I know that you want to know information and you don't like not knowing what's going on, so I'm telling you. She's in a hard spot with her classes being split on Wednesday and Thursday, and everybody being in sim lab and all of these, and the LPNs, and they have contracts where they're guaranteed they only have to be at school certain times. And it's just a lot more complicated than my class is, since I'm on Fridays and we're all basically together. But just know she's not a one-woman game, and she's doing what she's told, and she's trying to help. And y'all got to be nice. So now you can yell at me if you want to, so we can get it all out of your system, and I won't take offense. Do it now. Give me all your anger. I'm waiting. I got some from my last class. Or just some explanations, I guess.
I think we're just the quiet class.
Well, I mean, but do you understand what I'm saying? Do you
Absolutely.
Excuse me. I have a
Yes.
question,
Yes,
Miss
ma'am.
Knighton. Yes, we understand what you're saying, but I have a question.
Okay.
I know you're not talking, and I'm not talking on behalf of your class now, but since you brought up the issue, is there a way we can, like for us, took the survey with regards going to school to take the test, is there a way we can retrieve that back? Because honestly, for once, I for one misunderstood the fact that we had to still pay ProctorU, to take the test. So I'll prefer to like sit in my home and still pay the ProctorU rather than going to school on the day, because on that same day, like on Wednesdays, we have a pharmacology class, and having to drive from Benton to school, I'm going to be, rushing based on the time of the test and the time of the lecture. So is there a way we can I want to retrieve this the survey I took, because I had sent a mail, but I didn't get a response with regards that.
Yes. So all of your responses are going to be given back to you. It's all changed. Our meeting, guys, didn't end until almost 6 o'clock last night. So I don't think Ms. Humphrey has had a chance to reach out to you yet and let you know the new plan. Am I correct in that?
I haven't heard anything.
Yeah. So I know that you may have signed up to come to class, to come on campus, but that's not an option anymore. So she will, and she's also working with Ms. Durrell, looking at the SimLab schedules and working with Ms. Burrows to fix all of this. And it's just basically going to revert back to how it was with Proctor U, unless you have a specific internet issue and you need to come on campus.
So do you know if she's doing anything about the like me, I have that farm class from 8 to 9, and it's normally 8:15 to 9:15.
Uh-huh.
You know if she's doing anything time-wise? Because like that's literally going from one class to straight into a test, like
Well, you're
barely having
missing
time to
15
sign
minutes.
in.
Does that have to do with SimLab or just with farm?
No, that's with farm.
That's farm to like, because Miss Humphrey wants her test at 9 on Wednesdays,
Uh-huh.
and that's what time my class is supposed to end at 9:15.
9:15 actually.
Yeah.
You know,
Well, but for me, my issue is I start SimLab at 10 o'clock, so I'm in the 8 to 9 farm lecture. So if I have an exam in farm that morning, there's no way, because my test times are going to overlap, and I'm still going to have to drive to school for SimLab.
yeah, so that's why she's so stressed out, because there's so many different issues with the different students, from the LPN to the Wednesday students to the Thursday students, whether it's farm or SimLab. So all of that is being worked out right now as we speak. And just try to be patient and know that no one is going to be expected to come to school to take the test. And the SimLab and the farm issues are being worked out on her end, and she'll just get back with you. It's so confusing for me even. I can't begin to tell you what her solution is, but I heard them talk about it, and I know there is one, and she will reach out to you about that.
Well, I know I appreciate
overthink.
y'all, working all of it out, but I know it's stressful for all parties involved.
And I know you need to know so you can schedule your test on Proctor U. So just, really, guys, all I can say is know that you're not alone in the stress of it, because there's not an easy solution, and we're trying to figure it out. It seems easy for my class, but that's only because my class is on Friday and I've got
Huh?
anyway, just kind of put that on hold for a minute and share the love, let your light shine, be patient. Just be patient, but do expect to have to do Proctor U. That's really the only thing I can tell you 100%. Okay.
Thank you.
I'm sorry if I
Thank you.
sounded harsh. I'm not trying to be mean. I know I sounded mean, but I'm not trying to be mean.
Thank you. I'm glad you at least gave us an update.
That's all I was trying to do, just let you know what's going on, because I think that's where a lot of the frustration comes from, is feeling like you just don't know what's happening.
Yeah,
and
the
everybody
unknown.
feels out of the loop, and it's confusing. So I just wanted you to know that we're aware and we're trying very hard to fix it.
Yes, ma'am.
All right, y'all, let me know if you have any questions while you're studying, and don't forget to get your student test questions loaded by Monday night, okay?
Thank you.
All right.
Thank you.
Thank you.
Thank you.
See y'all later. Bye.
All right,
Bye-bye.
bye.
Bye. Have a good day.
See you.